For tonight, we have a fantastic speaker. And before I jump into that, I want to introduce you to the co-host of the evening, who will introduce our speaker. The lecture for tonight is Genetics Update 2021. And Dr. Robin Clark is going to share with us new treatments and approaches. And to introduce our wonderful speaker, I want to introduce to you Dr. Mitchell Goldstein, who is the AAP California Chapter 2 area representative in San Bernardino County. And he is also the editor-in-chief for Neonatology Today. With you, Dr. Goldstein.
Thank you. It gives me great pleasure to introduce Dr. Clark. She graduated from the University of Arizona College of Medicine in Tucson in 1978, completed her residency in pediatrics at Hospital at the University of Arizona Medical Center in Tucson. She completed her fellowship in clinical genetics and clinical cytogenetics in Los Angeles. She's had further training at the Hospital for Sick Children at Great Ormond Street in London with Doctors Robin Winter and Michael Bradster, participating in the undiagnosed cases within the London Dysmorphology database. In 1986, she returned to Southern California with a focus on prenatal diagnosis, craniofacial genetics, dysmorphology in the newborn, cytogenetics, and cancer genetics. Comprehensive Cancer Center at USC, Dr. Clark headed the Cancer Genetics Unit from 1997 to 2002. However, in 2002, she has been the chief of the Division of Clinical Genetics in the Department of Pediatrics at Loma Linda University School of Medicine, where we now appreciate her devotion and her in-depth consultations. Published many manuscripts and chapters in academic journals and textbooks. She and Dr. Cynthia Curry are the authors of Genetic Consultations in the Newborn, published by Oxford University Press in 2019. Dr. Clark also writes The Genetic Corner, a monthly report in Neonatology Today. Neonatology Today, all one word, .net or .org, that features informative clinical cases from Dr. Clark's practice in genetic diagnoses and treatment in the newborn. The link to Dr. Clark's book can be found on page 134 of the July edition of Neonatology Today. With that, it gives me great pleasure to present Dr. Clark.
Thank you for your kind introduction, Mitch. Now let's see, I will need to share my screen so we can get started. And from here, we'll make it full size. So welcome, and I have to say, I am recognizing so many names in the list that I wish I had time to chat. Maybe afterward we can say hello. I wanted to title this, well, actually the first slide is not showing up. So let's go back, because I wanted to title this Old Diagnoses and updates, because this photograph is what you might have seen a few years ago had you come to Loma Linda. It represents the Good Samaritan. For a few minutes there, I think there were masks on these sculptures, and I wish I had been able to get a photograph of that. But now you'd see a totally different scene, because we have new buildings that we have just moved into. There's a big campus transformation process. And this is a rendition of what those new buildings look like. So it's an update for us of an old campus, and an update for us tonight in terms of old diagnoses. So I don't have anything to disclose. Learning objectives, I'm going to focus on these 5 conditions that I think general pediatricians and all specialists will have seen fairly commonly in their practices. And each one of these represents patients that I've seen recently and taken care of who've had these comorbidities or sequelae that I think opens up a new era in treatment by having a better understanding of the molecular basis of the diseases in these conditions. So we'll start with Down syndrome, talk about Klinefelter, achondroplasia, tuberous sclerosis, and Klippel-Trenaunay syndrome. The first is Down syndrome, and I was familiar with the transient leukemoid reaction that is fairly commonly seen in Down syndrome. It has a new name now, transient abnormal myelopoiesis, or TAM. And it isn't as rare as you might think. It happens in at least 10% of babies with Down syndrome, and probably more that are subclinical. It was always considered a benign, self-limiting condition that you could be reassuring about because they almost always cleared without therapy. And there was, by 3 months, there would be a resolution. And so it would be demonstrated by blasts in the peripheral blood. And most of these babies are asymptomatic. So unless you did a smear and a diff, you might miss it. In some babies, it's not even evident on the diff because they only have a very small clone. But with molecular techniques, we can find these small clones. And these babies have been called silent TAM. The reason why this might be important is because this group goes on to have a higher risk for myeloid leukemia associated with Down syndrome. And it was only recently that I saw my first patient who had serious sequelae from TAM. This child, and in about 15 to 30% of babies with TAM, they do have these serious sequelae. This child had hepatosplenomegaly, evidence of liver dysfunction, jaundice, coagulopathy. The portal vein was partially thrombosed. There was also bleeding in the brain, so there was some disseminated intravascular coagulation. And then there was evidence of liver fibrosis. There was increased portal tension. You could see a Medusa's head on the baby's abdomen with dilation of the surface vessels that were going into the thorax, or coming from the abdomen. So this child had generalized edema, had anemia, had thrombocytopenia, had leukocytosis. This was a very sick baby. These children have a risk of death once you get into the serious TAM phenotype, serious risk of death that approximates 10% or more. And the rate of progression to MLDS, or the myeloid leukemia of Down syndrome, is approximately 20%. So it's a very serious disease. It's not always benign. So this was kind of a surprise. Children with Down syndrome have about a 10 to 20-fold increased risk of developing acute leukemia of the acute megakaryoblast type or acute myeloid type. And the MLDS subtype is 500 times higher in children with Down syndrome than in children without Down syndrome. And almost all of them present in the first 4 years of life. So there has been a recommendation to check smears, do CBCs every 6 months in kids with Down syndrome. But even if we find blasts, these pre-leukemic features only progress to a full leukemia in 20 to 30%. But there is therapy with cytarabine. They're exquisitely sensitive to cytarabine, even in low doses. So this is very useful treatment in the leukemia. But in the United States, it hasn't really been used for these severe TAMs. but in other countries it has been. So this is just a review from a children's oncology group showing that reported a prospective study of 48 children with Down syndrome and transient abnormal myelopoiesis. Leukemia occurred in 19% of these infants at a mean age of 20 months. Early death was reported in 17%, and it was significantly correlated with a higher white count at diagnosis, increased bilirubin and liver enzymes, and failure to normalize that blood count. So there is a higher risk group within the TAM group that we might identify not only for their increased risk for progression to leukemia, but for their higher likelihood of death. And the question is it worth testing? I mean, is it worth treating these children? Will their outcome be better? So first of all, TAM is not a postnatal disease. It's a fetal disease. It starts in the liver during fetal life, where hematopoiesis is going on. The bone marrow is often clear of the blasts, so we don't even recommend doing a bone marrow aspirate because you may find no blasts. They may all be coming from the liver in terms of the site which produces these. Now, they all have an acquired somatic mutation in a gene called GATA1, and that is a pre-mutation that is present in all of these children who go on to have full leukemia. So there's clinical TAM, there's silent TAM, but only a percentage of them go on to develop the myeloid leukemia of Down syndrome. But nevertheless, it's a marker for the group that is at increased risk. So knowing that there is this GATA1 somatic variant should give us a handle on a group that is at higher risk. Now, if you go to the middle of this slide, you'll see that in order to get to MLDS, you have to go through the additional genetic mutations portal. And that's where a lot of these kids, they don't get the second hits, the third hits that will allow them to go into full leukemia. So we know that TAM is a precursor to MLDS. It is not a necessary step, but it's not sufficient to get to MLDS. So the question is, how should we proceed? In a study called a prevention trial, the TMD prevention trial, they showed that there was improved survival among 43 infants with TAM who were treated with low-dose cytarabine. So it reduces mortality in this group, and you can see survival was 80% in the treated group and 67% in the non-treated group. The numbers were small, but I believe there was a statistical significance here. Let me move this up. Sorry. See if I can make this go away. Yeah. So treatment, however, did not prevent disease progression. It did improve survival. So now the question is, knowing what we know, should we change our approach? Let's see. Now I'm not able to, there we go. So the important points here are that the transient amyloid abnormal myelopoiesis is not always benign. It can be severe, and in those cases, it can not only lead to MLDS, but it can lead to death from liver fibrosis. And low-dose cytarabine decreases mortality in severe TAM. The GATA1 variant is the initial somatic change that seems to be the common change that is present for all MLDS, but it's not sufficient. And I put this here that it's not currently the standard of care to check for GATA1 clonal variants in all patients with Down syndrome. But I believe that that will be the case eventually when we have enough treatment that is able to change, to show a significant change in mortality and to show perhaps less progression to cancer, I think that will change. So I think this is something to watch. But for now, I think what's important to do is to order peripheral blood smears with a differential in all infants with Down syndrome at birth and every 3 months until age 4, because the ones who have transient abnormal myelopoiesis are the at-risk group for myeloid leukemia. And we suggest referring babies with TAM to genetics and hemonc so that they can be followed appropriately. And those babies I would test for GATA1 variants. This is just a slide to show you blasts with their large homogeneous nuclei and cytoplasmic blebs. But again, they won't be present in all of the patients who have a transient abnormal myelopoiesis, because some of them, the clone is so small that it's only present, still in the hematopoietic tissue, but it would be detectable with a GATA1 test. So I'm going to go on now to Klinefelter syndrome, which is actually more common than Down syndrome. It is the most common chromosome disorder in men. Among live-born boys, about 1 in 500 will have Klinefelter syndrome. So in your practice, for every 2 children you see with Down syndrome, there are 3 boys with Klinefelter syndrome, and you may not be aware of them because most of them are diagnosed in adulthood, at least until recently. Most of those can be diagnosed with a karyotype. The majority are just straight 47XXY, but in about 10 to 20%, there's mosaicism with a normal cell line, or there's an isochromosome X or a higher number of X chromosomes, which have more symptoms, more intellectual disability, the more X chromosomes there are. So if you have a child with Klinefelter syndrome who has comorbidities, we recommend adding a microarray to see if you can identify other changes. So Klinefelter syndrome is largely undiagnosed, or at least underdiagnosed in the pediatric age group. And only 25 to 40% are ever diagnosed. But now that prenatal diagnosis group is getting bigger because we have better screening tools. But before we had them, this was usually an incidental finding in somebody who had an amniocentesis for another reason, like advanced maternal age, for instance. And we might find a small number of children who had learning disabilities or brought to medical attention for some other reason before puberty, but most of them are diagnosed at puberty or beyond because of their endocrine problems. Androgen deficiency affects endocrine, but it also affects central nervous system and neurodevelopmental function. There is a distinct effect on the brain from testosterone, and having low testosterone levels in childhood seems to have an effect because we see not just these typical features of hypogonadism and smaller undescended testes, micropenis, etc. We see a behavioral phenotype. These children have more hypotonia, they are more passive, there's more speech delay, they have delays in, they have more anxiety, they have more dyslexia, more dysgraphia, and their verbal IQs are usually less than their performance IQs. But even still, their IQs are usually within the normal range. There's a decrement of maybe 9 to 10 IQ points compared to their siblings. If we use their siblings as a control. But usually that decrement isn't enough to take them out of the normal range of intelligence. But like I said, the higher numbers of X chromosome, those do have more severe phenotype and a much higher diagnostic rate. So typically, a prenatal diagnosis would be fortuitous based on some other indication that brought a mother to an amniocentesis. The young child is usually clinically silent and has infrequent signs. And it's only later in adulthood that you see with azoospermia and infertility that more diagnoses are made. This is being inverted now with NIPT. Non-invasive prenatal testing is also called cell-free DNA, cell-free fetal DNA. Actually, most of the DNA originates from the placenta. The placenta does come from the same egg and sperm that make the fetus, but the placentas have more variation in their DNA. And so we don't get, it's really not a diagnostic test. It is a screening test. But still, it is widely used now, probably since about 2012. It's been commercially available in many formats, different molecular approaches, but all related to comparing what's in the buffy coat, which is the white cells, which would have maternal DNA in them, and comparing that to DNA extracted from the plasma. So we're used to seeing a true positive, a false positive, and a positive predictive value. And for the sex chromosome mosaic, for the sex chromosome abnormalities, we don't have as high a positive predictive value as we do for things like trisomy 21. And you can see here on this list, on this graph, Turner syndrome has a particularly low positive predictive value of about 30%. And compared to that, Klinefelter syndrome is much better with a positive predictive value of about 80%, 75 to 80%, based on small numbers, but nevertheless, what we're seeing now is prenatal diagnosis through NIPT of Klinefelter syndrome. So we're getting these babies in the normal nursery. Mom had a positive NIPT. It showed Klinefelter syndrome. What should we do? Oftentimes, these are completely normal looking boys. There'd be nothing that you would recommend if you just saw this child as part of a normal exam. But knowing that there's this NIPT with a positive risk for Klinefelter syndrome, what should you do? We suggest going ahead and making that diagnosis as early as possible because there are benefits to having an early diagnosis. First of all, you can anticipate the needs in school instead of waiting for them to appear, which, always when you start with school failure, it is difficult to move out of that trajectory. So it's much better to add the support that these kids need before they get to school age, starting with speech therapy, learning support. But there is another aspect to this. It turns out that there is normally a mini puberty in boys where there's a slight raise in the testosterone level from 2 to 24 weeks. And that has an impact on brain development as well as masculinization and social behaviors. And boys with Klinefelter syndrome have a very much diminished testosterone rise at that point, and they don't have the same effects. So researchers have looked at mimicking that mini puberty for boys with Klinefelter by giving them low dose early hormonal treatment. And this paper that I'm referenced here followed 175 boys who were grouped into early testosterone treatment and no testosterone treatment. And testosterone treatment was 25 milligrams of testosterone in 3 different injections monthly. So in the group that were treated with early hormone therapy, they scored significantly higher on expressive language and on auditory comprehension than the group that did not get this enhanced mini puberty, this early hormonal treatment. So that's the question. Is there a new paradigm now that we have access to early diagnosis? Can we offer more than just anticipatory help in terms of learning disabilities, physical therapy? Can we now offer early hormonal therapy? So points to know. Klinefelter syndrome is common. It's more common than Down syndrome, and you can pretty much count the number of children you have but don't know about in your practice by dividing your Down syndrome population in half and multiplying it by 3. That should give you your Klinefelter syndrome population. Klinefelter syndrome is underdiagnosed, but that's changing because of NIPT, and we're going to be making more diagnoses in the newborn period, which will bring us to the point where we're going to have to ask if low dose early testosterone therapy in infancy can improve outcome. So things to do: follow up positive NIPT with a karyotype, order a karyotype in babies with small penis, plus or minus bilateral undescended testes, especially those who have not spontaneously descended their testes by 12 months. That is a group at higher risk for Klinefelter syndrome, and refer promptly to genetics and endocrine, where we can at least discuss the pros and cons of early hormonal therapy. So I'm moving on to achondroplasia. Also common, it's the most common skeletal dysplasia in man. It occurs roughly in 1 in 15,000 to 1 in 25,000 in the general population. 80% of cases are sporadic, which means that their parents are of normal stature. This is highly associated with advanced paternal age, and almost every new mutation occurs on the chromosome that was derived from sperm. And that's just because there are more new mutations that occur in sperm because of the many cell divisions that sperm go through. The achondroplasia is 100% penetrant. It's an autosomal dominant trait caused by an activating variant in FGFR3. So the clinical features should be evident, but I think they're often so cute that these kids get passed over as being normal. They have short limbs that's primarily short in the upper part of the extremity, which is called rhizomelia. Their short stature is disproportionate, and they may not be short at birth. The birth weight is usually normal. Their hands have an unusual trident appearance with a wider gap between the middle and ring fingers. And they are macrocephalic with a frontal bossing and a depressed nasal bridge. Most of these kids are hypotonic, and they have motor delays. They have sleep disordered breathing, often obstructive, but also central, and they can have snoring. But some of them also have ankylosing and hyperreflexia, which is worrying because we know that the foramen magnum is small. So I mentioned that it was an activating mutation, and I think that's important because FGFR3 negatively regulates bone growth. So it is a brake. It is like putting your foot on the brake and slowing down growth. That is its normal function. So an activating mutation will be like putting on the brake too soon and too long. And that is why FGFR3 variants that cause achondroplasia cause short stature, whereas other variants in this gene, and here is a schematic showing the variants that in different parts of the protein, other variants can cause different conditions, including craniosynostosis, which is bone overgrowth. So you can see that there are only about 4 places on this schematic where the variants cause achondroplasia. 2 of them are in this third extracellular domain, and 2 of them are in the transmembrane domain. The other variants cause other recognized syndromes. So how does it work? So the typical bone growth shows these columns of chondrocytes that as they get more and more mature, have a different phenotype. They move up into this resting chondrocyte zone, and that is where growth occurs. And FGFR3 inhibits both the chondrocyte proliferation and differentiation. And I think you can see in these rather complicated schema on the left that FGFR3 on the top has an arrow to map K, and that has a stop, not an arrow, that goes to the box chondrocyte differentiation. And you can see in a little more detail that MAPK initiates SOX9, and SOX9 stops chondrocyte differentiation. And FGFR3 also stimulates STAT1, which goes to P21, which stops chondrocyte proliferation. So there are various ways that FGFR3 acts on the chondrocytes to stop. So we need it to work. We just don't need it to work all the time. So this gives us an opportunity to figure out how to inhibit by changing downstream signaling. But before we do that, I want to talk about what you do when you see a baby with achondroplasia and why it's important to examine the baby carefully, because infants and toddlers with achondroplasia are at the highest risk in their lives for spinal cord compression. Best identified with T2 weighted MRI images, but it can also be identified with CAT scan. So there is an increased risk of sudden death. I can't call it SIDS because SIDS implies a lack of known cause. But there is an increased risk of sudden death in infancy, varying from 1 in 200 children to 7% in some studies of infants with achondroplasia. And this is due to chronic cervical spinal cord compression or acute compression and brainstem compression with central apnea. So we see more alties in achondroplasia. We see kids with acute life-threatening events under age 1. They are more common than the percentage above, which is the number of sudden deaths. So in one study by Lejar, there were 3.8% of their group, 18 out of 477, had acute life-threatening events, but it was higher in males. These present as apneic events or seizures, and they happen most often in car seats. And that's because the head is flexed and the baby's heads are not supported. And we just recently had such a baby airlifted into our medical center because of an ALTI, and baby had achondroplasia that had not been recognized. Foramen Magnum dimensions are reduced in infants with achondroplasia, and they enlarge with age, which makes the infancy a high-risk time. And rates of decompression surgery vary because there are no specific guidelines, and it's all up to the neurosurgeons who examine the child. The picture that I'm showing you is from Rich Pauly's paper in 1984, and that really brought to attention the need to look at the foramen magnum and to see, you can see in this picture, there are cystic lesions that document chronic hypoxic damage. So there are no evidence-based guidelines, but the AAP has a consensus expert opinion that advocates neuroimaging and polysomnographs for all infants with achondroplasia. Now, unfortunately, there is no correlation between polysomnographs and later cord compression. It is not sensitive. Similarly, clinical exam, neuroexam, is not sensitive. Both of these are poor predictors of spinal cord compression. So they're moving toward recommending foramen magnum and cord imaging for all infants with achondroplasia. And Chung et al. developed a Foramen Magnum score showing that only 2 out of 36 in their group had no evidence of Foramen Magnum narrowing. And that would be this AFMS0 group. So that is almost none of the kids with achondroplasia are in that group. Almost all of them have some degree of Foramen Magnum narrowing, but it was the group that showed loss of CSF space and cord compression. That's AFMS3, and cord compression and signal changes indicating myelomalacia in the brainstem, AFMS4. That group is unfortunately very common, representing 50% of all children with achondroplasia, probably why they have hypotonia. Sleep disordered breathing correlates with this Foramen Magnum score. So it's important to understand that although, a clinical exam is important and knowing about the hyperreflexia is good and doing the sleep study is good, it does not correlate or predict severe cord stenosis. And it would have missed in this study 5 infants who had the higher risk, those AFMS 3 and 4 scores. So this is really a plea to diagnose early and follow up with MRI. I know I've had several patients referred because the pediatrician wasn't sure if it was achondroplasia. And in order to get in to see us, it took so many months that the child actually had the event before they could even get evaluated. So that's partly why I want to highlight this today, because I think pediatricians, general pediatricians and specialists can make a big difference by just starting this process. Now, second point about achondroplasia is relating to that activating mutation in FGFR3. This is the downstream signaling that results in diminished chondrocyte proliferation and differentiation. And by interfering in this pathway with a C-natriuretic peptide analog called BMN 111, we can block some of the activating effects, and we can return some of the chondrocyte proliferation and differentiation functionality by interrupting that inhibition cycle. So I'll show you some results that I think are very encouraging. This drug, BMN 111, has a name, Vosoritide. It's been studied in a phase 3 trial in children ages 5 to 18. This was completed in 121 children in 24 sites in 7 countries with a randomized double-blind protocol. And it showed an increased growth velocity of 1.57 centimeters a year in the treated group. So this is the chief, the lead author, and he, of course, wanted to treat younger children because of the benefit there, but they decided to start with the older children first to show safety and efficacy. And now they're working backwards into the younger groups. There is some data in the 2 to 5 year group and not enough data, but some in infancy. The question that I have for this study is, will it change Foramen Magnum dimensions, and will there be fewer altes and sudden deaths in the Vosoritide group? So may we actually save lives as well as increasing growth? So Vosoritide is pending FDA approval based on the complete data from the 5 to 18-year-old study and some data from the 2 to 5 year cohort. In Europe, there was a positive opinion recommending marketing authorization from age 2. So they accepted the 2 year to 5 year cohort data. The question is whether the FDA will do the same. And then moving it back into infancy, where it could possibly save lives, will be the next step. We expect that will get a decision from the FDA this year, and we will hopefully be able to start using Vosoritide. It's a daily injection for children with achondroplasia at the end of this year. There are other CNP analog therapies in development in other companies, so there's going to be more to choose from than just this one drug. So things to know: this is achondroplasia is due to an activating FGFR3 variant that inhibits growth. Foramen magnum stenosis contributes to an increased risk of sudden death in Alties. 50% of affected infants have significant cord changes on T2 weighted MRI. Clinical exam and polysomnogram alone are poor predictors. Sleep disordered breathing is common, and C-type natriuretic peptide analogs are on the horizon. So the things to do are to follow AAP guidelines and make sure that all of these children get imaged. Their heads are supported, especially in car seats. We recommend avoiding soft backed strollers like umbrella strollers or front loading baby carriers or soft bouncy seats, which will cause more flexion of the neck. We suggest prompt referral to genetics, and that may mean calling us and letting us know this is a stat referral, but not waiting for the imaging, but going ahead in the newborn period with that. So I'm moving on to tuberous sclerosis, another fairly common disorder. It occurs in about 1 in 6,000 newborns. About 50,000 people in the United States are affected with tuberous sclerosis. Tuberous sclerosis is due to a loss of function mutation in tumor suppressors TSC1 or TSC2, which are negative regulators of the mTOR pathway. So when you have a loss of function variant in a negative regulator, it means you're activating the mTOR pathway. 2/3 of these patients have a mutation that's de novo, some of which are mosaic, and 1/3 are familial. The phenotype is very variable, and the TSC1 type is less severe in general than the TSC2 type. Usually there are benign growths in tumors, heart, lungs, skin, and eyes that progress over time, and you can see in the graph below how they progress over time. The cortical tubers and the subependymal nodules can progress to subependymal giant cell astrocytomas, and epilepsy, neurodevelopmental delay, intellectual disability, and autism spectrum disorders seem to be consequences of epilepsy. And epilepsy is common. About 85% develop seizures, usually within the first year. 1/3 of those are infantile spasms, and 2/3 develop refractory epilepsy, which is double the background risk in the epileptic population. And it seems that uncontrolled seizures and early onset of seizures are associated with cognitive comorbidities.
Once you pour it all.
And immediate seizure management is our best hope for preventing some of those sequelae. So the reason that these develop over time is because these tumors require a second hit. So the TSC lesions are more numerous as you get that second hit. You acquire your first hit in your genome, and then your second hit is a somatic variant, somatic mutation that happens only in the tuber itself or the lesion in the kidney, the lung, the brain. Treatment that reduces the number of second hits will likely reduce the disease burden and prolong the disease-free years. So we might be able to change those curves by starting treatment early. So
For NorCal?
I think we need to mute the group. Is there anyone who is not muted? Could you mute yourselves? Thank you. The mTOR pathway is activated, and you can see here that TSC1 and TSC2 normally have an inhibitory effect on mTOR. So by the mutations that cause tuberous sclerosis interrupt this and cause increased mTOR activity, which means that there's accelerated cell growth, proliferation, angiogenesis, protein translation. And mTOR inhibiting agents, which are already available because of their role in cancer, have been approved for FDA treatment of tuberous sclerosis associated tumors. They're now being used for SIGAs, for renal tumors, and for other manifestations of tuberous sclerosis. The question is whether they would be helpful for the neurocognitive phenotype. So Everolimus, which is an mTOR inhibitor, has been shown to be very effective. Here is a German study that followed 17 patients in 12 sites. It was a retrospective study. And they showed that among these indications, the results were that 14 out of 17 patients benefited from therapy, either by decrease in size of a tumor or decreased seizure frequency, regression of lymphedema, improvement in an arrhythmia. However, in the SIGA group and the epilepsy group, it was not 100% who benefited. 2 out of 4 children continued to have intractable epilepsy. So although taking your foot off the accelerator of the mTOR pathway helps, it didn't seem to be enough. So in that seizure group, there is a promising therapy that may prevent seizures, and that's vigabatrin. I say it wrong all the time. Vigabatrin. The majority of TSC-related seizures occur after asymptomatic epileptiform activity is noted on EEG, or an asymptomatic electrographic seizures are noted on EEG. So now the question is, should we be following these kids as soon as we make the diagnosis to identify a high-risk EEG pattern and treat early? Could we prevent seizures from starting and then reduce the burden of refractory seizures and intellectual disability and autism? So in Europe, the EPISTOP study was a prospective study involving 10 sites and 24 infants with tuberous sclerosis equal to or less than 4 months of age. None of them had clinical seizures or electrographic seizures on their baseline EEG. They had a monthly video EEG, and they received vigabatrin at either through a randomized controlled trial in 6 sites or an open label trial in 4 sites. They wanted it all to be randomized controlled trial, but the several of the ethics group committees would not approve it to be randomized controlled trial. And in those locations, it was a open label trial. So the infants in the open label trial were either given conventional anti-epileptic treatment started after the first seizure or EEG electrographic seizure, or it was used as preventive therapy after the epileptiform activity was identified. In 54 subjects, epileptiform activity was identified before seizures. So these are the children where it might have had a preventive effect. And 27 were in a randomized controlled trial and 27 were in an open label trial. So if we pool the analysis, we can see that the infants who developed clinical seizures developed them at a later time, day 614 in those who received preventive therapy, day 124 in those who did not. We had patients in the preventative group, and they were 3 times more likely to remain seizure-free than in the non-preventative group, and that's 46% versus 15%. At 24 months, the preventative treatment group reduced the risk of clinical seizures and drug-resistant epilepsy and infantile spasms. So they conclude that preventative treatment is safe and it modifies the natural history of tuberous sclerosis, reducing the risk of and severity of epilepsy. So we are now recommending that in all of our children who have early diagnosis for tuberous sclerosis. And that would mean starting EEGs and starting therapy before the first evidence of clinical seizures. Points to know: tuberous sclerosis is a multi-system disorder with a variable but often serious debilitating sequelae. By inhibiting the mTOR pathway, it gives us an opportunity to intervene and treat with mTOR inhibitors. Pathogenic loss of function variants increase activity, and so we want to inhibit the mTOR pathway. We want to emulate what the TSC1 and TSC would do if they were functioning normally. Seizures are preceded by EEG abnormalities, and seizures seem to be the necessary and first step in intellectual disability and autism in a lot of children with TSC. Preventing seizures reduces these TSC-associated neuropsychiatric disorders, and Everolimus can ameliorate tumors and prevent some seizures, but vigabatrin even more so. So things to do: refer infants to a TSC clinic, and I've got Dr. Ashwell's picture here because I want to thank him for everything he's taught me about tuberous sclerosis. Dr. Ashwell started the first tuberous sclerosis clinic at Loma Linda, which is the first clinic west of St. Louis in about, I think it was 2009, he said. And this clinic sees both adults and children, one of the few clinics that does so. So we recommend early involvement before symptoms start as a way to prevent sequelae. And then we're down to our last, I might just time this perfectly if I get through it. So the last condition I want to talk about is Klippel-Trenaunay syndrome, which is a sporadic vascular malformation with limb asymmetry and overgrowth. There is disproportionate growth of cutaneous, capillary, lymphatic, and venous malformations that cause bulky soft tissue overgrowth of the affected areas. Usually this is affecting the lower extremities, but it can also affect upper extremities, and it can be bilateral. It is usually focal, and was not considered genetic. Now we know differently. We know that this is a somatic variant of this gene called PIK3CA. So PIK3CA, depending upon where the mutation, in which tissue the somatic mutation is derived, you'll get a different clinical presentation. But again, PIK3CA is due to postzygotic activating mutations that turn on, so they are gain of function mutations that turn on the mTOR pathway. So again, we're trying to turn off the mTOR pathway. So although Everolimus was useful in TSC, it's not as useful in PIK3CA related overgrowth spectrum diseases, which we call as a group PROS. The test for PIK3CA needs to happen in an affected tissue. So we need actual tissue from the region involved. If we look in blood, we won't find the variant. The variant is only in the affected tissue. And these are some of the presentations and some of the names of the diseases based on the tissue of presentation. They have been described differently in the literature. Some are called Klippel-Trenaunay Weber. Sometimes it's called cloves. It can be isolated macrodactyly. You can see infiltrating facial lipomatosis. MCAP is macrocephaly and capillary malformation syndrome. So all of these stem from the same mutation, but just affecting different tissues. And then there are other genes that cause different vascular malformations in a variety of other genes in these pathways. All of them, whether it's in the mTOR pathway or the MEK pathway, lead to overgrowth. And so now this is where Klippel-Trenaunay sits in one of the PIK3CA group. So now that we are able to manipulate the mTOR pathway with treatment, we can look at drugs that are already known to affect tumors, in this case, breast cancer. PIK3CA positive breast cancer has been shown to respond to a drug, alpelisib, also called Piqray. It prolongs survival in breast cancer patients. So in the treatment group, the progression-free survival in the SOLAR-1 study was 11 months versus the placebo group, where it was 5.7 months. And about 40% of patients with hormone-positive breast cancer have activating mutations in PIK3CA. So this drug has been widely used and approved for breast cancer therapy. So now the question is it useful in kids with PROS or PIK3CA-related overgrowth syndromes? And this was trialed in a study involving a few very severely affected individuals who had bulky tumors, lipomatous tumors, and vascular malformations. And over time, there was a decrease in the size using volumetric MRI. So there is now a clinical trial where children with PIK3CA-related overgrowth that are greater than 2 years of age are eligible for this alpelisib treatment in a managed access program or a clinical trial sponsored by Novartis. So before, we would tell kids with Klippel-Trenaunay-Weber syndrome that there was no treatment. Now we are trying to actively enroll them in this, either by getting compassionate use from Novartis or by putting them in a clinical trial. And you can see there are others. This is where alpelisib figures right here in the PIK3CA. It inhibits there, but there are other mTOR inhibiting drugs. And we think that they're in even upstream. We think that this is just the beginning of an era of treating somatic variants. So points to know: Klippel-Trenaunay syndrome is caused by somatic activating mutations in PIK3CA. It occurs during embryogenesis and causes tissue overgrowth. It's only present in affected tissues, usually not detectable in blood. It is a PIK3CA related overgrowth disorder, and it does respond to alpelisib, which is a selective inhibitor of PIK3CA in the mTOR pathway. So we now want to see these kids with Klippel-Trenaunay syndrome early so that we can start therapy. So in summary, early diagnosis has a new urgency now in these common genetic diseases where treatment can affect, can improve lifestyle, can improve quality of life, may even improve survival. So we want to engage pediatricians in the active management of these disorders by increasing their participation. And we want them to refer early and often. And I want to thank you very much for your attention. You can certainly reach me with any questions or referrals. And for more up-to-date content, there is a book with my brain in it. And every month there is Dr. Goldstein's journal, which has a little contribution from us as well. So thanks very much. I appreciate your attention.